Good afternoon, everyone. So basically talking about one case, which is just a patient who was a 50 years old male. He had left corneal ulcer for 3 months, treated somewhere else. Diagnosed as possible herpetic. They have amniotic membrane for a month, but he have keeping relapsing. So using Zofirax, Cyclovir, and they have been vision 6-9, and this is very superficial corneal ulcer. The corneal incision is completely normal. It doesn't look like the typical of the herpes, but that's what I faced with. So I did corneal scrape, like a normal, just unrecognized ulcer. Once you just start basic, do corneal scrape, gram, GIMSA, and culture, and they send the PCR for herpes. And I just started broad spectrum antibiotic Brisivans that time, 4 times a day, 5 times a day is less, at least less toxic, and just waiting for the result where to go, because you don't know where to go. And funny enough, it came these 2 things. The problem is that gram stain, gram cocci, GIMSA, it came as fungus, okay? And that's where you make it even worse which direction you go. So I add amphotericin that time, because it's the fungal we worry about it. And I kept the Visivans, and the pain is less, and the epithelium start to heal, and gram stain come as staph aureus, but this is not specific, and still the patient Visivans, so it should affect that one. 1 week later, start to break again. And after 3 days, I just observed that time, and still the vision become even worse, and the epithelium defect start bigger. So 2 days after that, so I add the voriconazole and the traconazole, still the antifungal, we worry about it, but the culture after that, after 10 days, it came as 14 days, there's nothing grow as a grow. So it's just you feel you become confusing. The herpes simplex PCR was negative, so most likely there's not herpes. It never had herpes history, so that's most likely there's no herpes just treated. But there's a risk. It's just persistent cornea. You don't know where to go. And that time the option shall I do biopsy, such as the antibiotic fortified intensive, such as antifungal, or do back corneal cross-linking. I went for the last option really, the back cross-linking, because I was just confused where to go, and that at least the corneal cross-linking may help us. So I did corneal cross-linking. I just make a Vigamox 4 times, and just add steroid twice a day, just to reduce the inflammation of the cross-linking. Maybe controversial, some people start, maybe not, but just I want to quieten the eyes at low dose. With kept bandage contact lens. I stopped them for voriconazole, and just because I don't know, this herpetic is always in my mind, so I said better to keep a tablet as prophylactic cover, but I don't want to add any topical toxicity. And that's after the back, 1 day after the back cross-linking, and that's after 5 days, the epithelium defects start to heal, and this slowly the hairs become fainted, and the vision recovery this 30 days, and really patient recover very well. To good vision 6-6, no, and happy patient. After that's 9 weeks after the back cross-linking. So really, this is the one case where you don't know where to go, and that back cross-linking saved me. And some people, as you know, some people using for back cross-linking as for emergency, where you don't have desperate, you don't know where to go. The ultraviolet, as you know, it kills everything, but it works more on bacteria than the fungal dicant amoeba, and may help us to prevent need for emergency corneal graft. And but you remember, that's always work in superficial things. The cross-linking doesn't work deeper, so if someone deeper than 250 micron, it will not be as good. Take home message: need to take stepwise. When you have corneal ulcer, you don't know diagnosis, stop the antibiotic, whatever medication, and do corneal escape, do investigation. Back cross-linking is effective in selective case, especially if it's superficial corneal ulcer, but is traditional supposed to be contraindication for if pure herpetic. But if you mix it, you can use it and still maybe cover for anti-herpetic. And thank you very much.
Thank you, Professor Osama, for this nice presentation. My question: what was the final diagnosis? What is the etiology?
It's mixed, because the problem had gram stain cocci and yeast and culture staph. There's no clear, we don't know, but there's 2 positive.
And still the viral is maybe with a pathogenic organism.
Yeah, it's a mixed infection, but most likely there's no herpes, because we did after that, we did a blood test, but I always do sometimes serum to look for IgG, IgM. If both negative, that's give you a clue there's unlikely to be herpetic at all. But if it's positive, maybe had herpes at one stage, but IgM, it does both. So the serology also very useful for these cases, looking for herpes. But we have access to PCR, it's very effective, really, very powerful tool when it's epithelium defect. If it's herpetic, it will give you a good result. And thank you very much. I'm not sure if you want to introduce the next speaker.
The next speaker will be Dr. Namrata Sharma. She's going to talk about the biosynthetic cornea, the new frontier. Not here. Dr. Namrata.